Without much ado, may I request the Wiroc secretaries, Dr. Swapnil Keni and Dr. Sandeep Sonone, to please escort the Dr. R.J. Katrak Orator for Wiroc Grande 2015, Professor Dr. Shekhar M. Kumta, to the stage. Dr. Rustam Jamshedji Katrak, born in 1899, completed his MCH from England in 36, joined the JJ Hospital in 1940, moved to the BJ Vadia Children's Hospital in 1942, then to the KM Hospital in 1944, finally to the Sion Hospital in 1957. He is probably the only BOS president to have served as faculty at all the 4 teaching institutes in Mumbai. Founder president of the Bombay Orthopaedic Society in 1965, Dr. R.J. Katrak, was known to be a conservative pediatric surgeon who had perfected the art of CTEV manipulation and percutaneous stenotomies. Teacher to the late Dr. A.K. Thalwalkar, late Dr. K.T. Dholakia, and our founder secretary, Dr. Alan Vora, who was his last registrar, Dr. Katrak formed the Bombay Orthopaedic Club in the year 1965. He was the first Indian to be elected as fellow of Bombay Orthopaedic of the British Orthopaedic Association. The Dr. R.J. Katrak Oration is the highest honor bestowed on an invited orthopedic speaker of repute at Wiroc annually. It is a tribute to this legend, R.J. Katrak. Today, the Lion of Sion is here. Shekhar Madhukar Kumta. Born to Meena and Madhukar Kumta on July 27, 1957, Shekhar is the eldest of 3 siblings, Shekhar, Samir and Sujata. He was a sportsman par excellence, won intercollegiate, inter-school high jump competitions. That's him. He married Nutan Tambe, that's the lady. They had 3 children, Neha, Nilesh and Nihal. Academically, Dr. Kumta did his MS Orth from LTMGH with Professor Nandulad as his guide and mentor. He was always known as Lord Master's blue-eyed boy. He moved to the Prince of Wales Hospital, Chinese University of Hong Kong in 1989 and is presently the Assistant Dean of Medical Education at the CUHK, Chinese University of Hong Kong. He's always said, Narayan, Narayan. Pichhe Nama Ramchandra Surya Narayan, his closest friend and associate, and his buddy, Ramchandra Narayan, are the 2 people he worked with all his life in his training days. And then there is serendipity, a pleasant surprise today, that for the R.J. Katrak Oration, who was professor, head of the department at Sion, when Professor N.S. Lard worked with him and became professor, head of the department of Sion, that a Sion boy should deliver the R.J. Katrak Oration. And on a slightly personal note, the day I entered orthopedics, I was assaulted, and the assailant was traced by none other than my lecturer, Dr. Shekhar Kumta. The day Shekhar Kumta vacated his position as lecturer, yours truly got a chance to become the same. My first ever international presentation was at a conference in Hong Kong organized by Dr. Shekhar Kumta. Serendipity doesn't end there. Probably the most interesting. Dr. Shekhar M. Kumta is probably the only person who would have delivered both the K.T. Dholakia lecture after he's delivered the R.J. Katrak Oration today. He did so in Wiroc 1998. I happened to be the organizing secretary. The general body decided to have him as the K.T. Dholakia lecturer. And today, it's a matter of immense pride, pleasure, and satisfaction that I would be the person to garland and adorn the R.J. Katrak medal onto my dearest friend for life, Professor Dr. Shekhar Madhukar Kumta. Please, sir.
Ram, thank you very much. That was a very flattering description of me. I'm not sure whether I deserve all the accolades. But I want to state that we are an amazing fraternity of orthopedic surgeons. I was brought up in one, and not surprisingly, I think this fraternity spawns amazing mentorship. I'm not at all surprised that the great R.J. Katrak must have been a fantastic mentor. And I was very well nurtured and mentored by my mentor, Dr. Lard, and I think this fraternity continues. Needless to say, I am extremely honored to be here among such an august audience, particularly standing in front of some of the most distinguished men and women that I know, people who have nurtured the art of orthopedics, have trained me, have actually nurtured me. Some of them have been my teachers, although I did not work in their unit, so I'm also extremely humbled by this amazing invitation. I'm going to talk about something that I got exposed to when I moved over to Hong Kong, the world of oncologic surgery. And osteosarcoma in particular, being the most commonest primary malignant tumor in the young adult and the young pediatric population, is a fantastic modern success story. In fact, the 5-year survival rate now in specialized oncology units is a staggering 86%, and the 10-year survival is now approaching 70%. 91% of all patients undergo limb salvage, and patients and their parents expect much better function out of the salvage reconstruction and much better longevity. I think wide resection is an obligatory requirement. However, sometimes it means an unnecessary sacrifice of bone, perhaps even the contagious joint, simply by way of safety, rather than deal with the uncertainty of going into area that might be oncologically dangerous. Often it is also required to accommodate off-the-shelf prosthesis, and simply because to accommodate, for example, one resects a distal femur, just to accommodate a prosthesis, one has to drill into the proximal tibia, and in a growing child, that is almost certainly likely to affect growth. Another fantastic development that has helped in my journey here is the post-processing of radiological imaging has gone at such a fantastic pace that it allows very accurate and excellent visualization of anatomic structures, not only shape and dimensions, but you can make judgments on the functional characteristics, integrating them with anatomy. Because our visualization has become so good, and because we can integrate multiple perspectives, our judgment about where to resect has also become really very, very good. It's improved astronomically. Let me recapitulate a little bit of what margins are for solid tumor resection. The margin is best defined by looking at the reactive zone on a T2 weighted image. A radical margin is historical because we did not have access to imaging such as MRIs and CTs. So when in the 1970s people resected, they either did an amputation or they resected the whole compartment. Nowadays, because of CT and MRI, wide resection is the norm. It is feasible because of these investigations. However, there's a whole range of options between what is wide, and wide is a concept. It does not mean wide in terms of numbers and centimeters. Because we've been able to understand the margins much better and define them much better with better radiological imaging, instead of the conventional wide resection, with techniques such as navigation and post-processing of radiology images, we can go reasonably close to the tumor, yet be oncologically very safe. And that has opened up some staggering possibilities of resecting and salvaging the joint. And that's what I want to share with you, the paradigm of joint-sparing surgery. In fact, joint-sparing surgery, we were one of the first groups in the world to start this without the availability of sophisticated equipment such as navigation using CT and MRI. With better visualization of anatomy, we have become much more confident that our margins are safe. We can integrate a great deal of preoperative planning, integrate that with the design and manufacture of custom implants, and our ability to perform these resections reliably has improved tremendously. For those of you who may not be familiar with navigation-guided surgery, in tumors, it is always based on CT and MRI. Here's a navigation console, there's a tracking camera, a tracking device is mounted onto the patient's bone during surgery, and we look at the monitor. Registration registers the local anatomy during surgery to the preoperative CT and MR images that are integrated. In fact, you can integrate a variety of images, and they are very useful during surgery. Navigation in surgery is no different from navigation using the road. But what is interesting is you can navigate almost any form of instrument now by putting in a navigation tracker, and that gives us tremendous accessibility to understand where we are with reference to local anatomy and the imaging anatomy. In 2005, we helped Stryker develop a navigation planning system specifically dedicated for bone tumors. Another amazing development that helped us was the concept of osseous integration, especially with hydroxyapatite coating, tricalcium phosphate, and in recent years, the three-dimensional printed porous-coated implants. Bone growth is staggering when you have good HA coating or porosity with modern titanium reconstructed elements. And this allows short segment fixation. Because of this, we can resect and leave behind very tiny distal fragments and yet remain confident that they will unite with the host bone and the prosthesis. So here was a child with high-grade osteosarcoma. The question was, could you spare the knee? There would be a very small distal fragment. Would it survive? Would it integrate with the prosthesis? Our studies have shown that if we can spare the middle geniculate artery, which is an important supply to the distal femur, especially in a growing child, it is possible to retain even small fragments of bone. So here was the resection plan on the MRI. Then we used a variety of planning softwares. Here was the plan for resection done, and we also designed a custom prosthesis. We got manufactured from Stanmore Implants, UK. So that is the prosthesis initially designed on the computer program, the real prosthesis. It matches the resection plane exactly. So that's the planning on the navigation control. We've already marked the level of resection. The match is perfect. That's a template to guide us, put in our implant. There are some slots, and then the implant is a custom designed implant which fits in very well. So that was a child walking at 6 weeks, and at 4 months he's actually playing wushu in Guangzhou. Not only that, that tiny small distal fragment continues to grow, and I believe it continues to grow because of the excellent physiological function that is retained. And the growth of the remaining segment is really impressive, and you can see at 6 years, not only is the distal fragment growing, but even the proximal tibia grows almost compared to the opposite normal tibia. These prostheses allow us to lengthen. With a minimally invasive approach, you can lengthen the prosthesis and equalize the limb heights. Therefore, it has a distinct advantage over a pure biological type of fixation because it does not retain the growth once the growth plate is sacrificed. Here was another case we discussed at a world forum, and almost everybody said they would remove the entire femur, do a total femoral resection. That was conventional surgery, but could you actually spare the hip and the knee? And with our technique, almost certainly. So we did the same. We created the anatomy, reconstructed a solid model, designed an implant. The implant had a very, very precise fit with the anatomy. Here was a solid model. Here is the resection plane and the implant to fit exactly. We planned this on the navigation software. So you have one planning console and everything happens there. This is the surgical exposure. The proximal and the distal resections are mapped. There's a navigation tracker to guide us. That is the implant. It's positioned in, it fits in perfectly because it's resected exactly where it should be. And again, you can see at age 8, the distal fragment is growing. A tiny distal fragment when he was at age 5. And now 3 years later, the distal fragment is growing, is also viable as the bone scan shows. And you can see the proximal femoral neck also remodels, and at 36 months, it's looking quite normal. In fact, the kid is able to run and do all the activities. In fact, he's had 4 interval lengthenings with a minimal invasive approach, and even the proximal tibia is quite similar to the contralateral. And I believe this is because the limb is extremely physiological and can do all his activities. We then came to the conclusion that orthopedic surgeons don't have to just resect in a single plane. You can do multi-planar resections. Here was a 23-year-old man with a tumor in the distal femur. We did, again, the planning and prosthetic design, and that was a prosthesis that was designed to
Distal femoral joint-saving resection is planned and simulated in Mimix software. The resection consists of 3 planes that maximally preserve normal bone and soft tissue attachments, the femoral condylar insertion of anterior and posterior cruciate ligaments.
So that was a video that we put up on JBJS, and you can see with visualization, one can play around and understand very accurately the anatomical extent of the disease and what resection can or cannot be done. And then we did this joint sparing resection, and in fact, his knee is very stable, he cycles to work. So multiplanar resections and monoblock resections came to be in this manner. Here was a young girl who had a grade 2 chondrosarcoma. Again, joint sparing resection, we planned this resection on a CAD program, used the CAD program to design an implant, used the same planning in the navigation software, did then unblock resection and integrated that. And you can see at 6 months, she still has a little bit of an abductor lurch, but it's now 8 years and she is a recreational badminton player. As we were evolving in our computer planning and application, we also came to realize that not everybody has navigation systems. And that's how the cutting guide and the patient-specific implants evolved. Because we realized that we were planning on the solid model, we are planning using the same solid model to create an implant, we could then also use the industrial concept of jigs and fixtures and create a matching cutting guide. So we first did a cadaveric trial as a proof of concept, And then we just recently published this study. We did a cadaveric study comparing navigation with patient-specific instrumentation and cutting guides. And we were able to show that they were comparable, and cutting guides actually took less amount of time. And then came this child with an osteosarcoma. He had a pathological fracture. He had good response to chemotherapy and was definitely a potential candidate for joint sparing surgery. So here's a patient-specific cutting guide, how it looks. We've exposed the distal femur. There's a cutting guide in place. We always use a 3D printed model to try out to see how it feels. We look at the placement of the guide, and then there is a slot which allows us to cut. So the resection is very fast, much faster than even with navigation. And that's the reconstruction. As we were evolving, once again another challenge, a telangiectatic osteosarcoma. And the question was, can you actually spare the joint? Although the tumor was pretty close, we thought certainly you could spare half the joint. And then we did this cruciate sparing and submeniscal resection planning. With that, we designed a hemicondylar prosthesis, the thinking behind being that should the meniscus not get attached to the periphery, which was hydroxyapatite coated, maybe in later years we could replace this with a conventional joint replacement surface if required. And we used the cutting guide for the submeniscal resection. We trialed it in a 3D printed model. The resection was perfect, and so is the reconstruction, although I would say the reconstruction is not as perfect as it really should be. However, the cruciates are spared, the femur articulates with the meniscus, and the child has a very, very stable joint, and she's able to run and skip. We also came to realize that biomechanical considerations could be utilized, especially finite element analysis. We could utilize that because we are already planning on the computer to make judgments where to put in your screws and your implants. So here was a 65-year-old with a tumor in the acetabulum, which most people would have resected the acetabulum and replaced with a pelvic prosthesis. But we thought this would be unnecessary. And then we designed a hemiacetabular sparing resection. What is important is you can actually make judgments using the CT and functional characteristics of the bone and integrate these material characteristics into designing your screws and the proper placement of screws. So we optimize the placement of screws into the best quality of bone by looking at the CT data and design this implant. We also designed a patient-specific jig to enable this resection. And for those of you who are familiar with pelvic and acetabular resections, know it's not an easy thing to do this. And then we 3D printed this titanium implant with the optimal porosity that matched this patient's bone. And you can see the reconstruction. In fact, the bone integrates very well with this prosthesis, and he's standing on the affected side without a Trendelenburg lurch. So I want to actually conclude this session by saying, for me, it has been a really long and fascinating journey. We coined this term computer-assisted tumor surgery, CATS, and obviously after CATS there must be a RAT. So we also started working on RATS, which is robotic-assisted tumor surgery. We were working with Imperial College on their robot Acrobot before the robot wars started, and then Mako bought Acrobot and Stryker bought Mako. And I don't know what's happened to robotic-assisted tumor surgery because Stryker owns 95% of IP. So we also, in this development, developed the navigated endoscope-assisted tumor surgery. We were the first in the world to publish this. In fact, we have published the only manual on the practical guide to tumor surgery, and we've helped surgeons from 23 countries, and it's been fascinating interacting with a variety of people from all over the world and going to places all over the world to share what we have acquired. In conclusion, I want to say there are lessons that I have learned. It's very important, and this is a very, very memorable photograph. I remember this was when we were working in Dr. Lad and Dr. Ingal Halikar's unit, and I think Purushottam Prabhu is there. I think he will drown if he now starts to swim, but he can see him in this image. 3 things that I've learned. The best investment in your surgery, really the best investment in your surgery, and I can tell you from first-hand experience, without a doubt, it's pre-operative planning. Before surgeons had the vanity, I could go into the theater and do anything. But once I started doing pre-operative planning, I realized that is the best investment in surgery, no matter whether you do computer-assisted surgery or what. What is the strongest motivation for progress? For me, the strongest motivation has been critique. It's in academics, your friends are the ones who are not afraid to critique you. And for me, taking criticism has been the strongest compliment and the best driver for progress. What is the best strategy for winning? And without doubt, this has worked in our case, because you can see what I've shown very few people in the world have been able to accomplish, and we are proud to say we are sharing this technology. But it's never about a single person. The best strategy for winning is teamwork. And in our team, we have engineers, we have software designers, we have computer science students, we have colleagues, we have students from other faculties and disciplines. They come around, they play with our designs, they play with our software and give us a lot of critique, a lot of feedback, and together is the collective wisdom. I want to end this by one of the very, very famous quotes which has really come up nowadays. Ever tried, ever failed? No matter, try again, fail better. What it really means is one should not rest on one's laurels, and success should be one of the drivers for better success. And with this, I want to thank you all for giving me this august opportunity to be with you. Thank you very much.
Thank you very much, Professor Dr. Shekhar Kumta. The Bombay Orthopaedic Society feels humbled and thanks Professor Dr. Shekhar Kumta for delivering the R.J. Katrak Oration on the changing paradigm of limb salvage surgery at the Wiroc Grande 2015 on December 24th, 2015, Mumbai. Thank you very much, Dr. Kumta. We salute you. Before I hand over this to Dr. Kumta, may I also acknowledge that Dr. Professor Shekhar Kumta has very generously agreed to partner with the Bombay Orthopaedic Society in a Case Masalawala Best Paper Award for this year, which will include a 2-week visitation to the Prince of Wales Hospital, Chinese University of Hong Kong, where all this brilliant work has been done. We thank you, Dr. Kumta. Thank you so much.